For those who are already on, I just want to go ahead and before we begin, if anyone does have some questions at the end of the presentation, just type them in the chat box and we'll be sure to get to them and address them at the end once we wrap up. But having said that, let me go ahead and just thank everybody for joining the team here at Subchondral Solutions this evening for our continuance of our educational webinar series. My name is Brandon Milliken. I'm the Southeastern Regional Manager. And as we've mentioned before, our goal with this is to highlight various educational topics in the areas of joint, bone, and motion preservation through introducing a multitude of practicing physicians across the country whose surgical profiles engage these very issues and topics. Tonight, it's going to be my great pleasure to introduce Dr. Eugene Batelli out of Naples, Florida. Dr. Batelli's been practicing and actively working in the various capacities in the medical field for over 24 years. He's a diplomate of the American Board of Foot and Ankle Surgery, where he's double board certified in foot and ankle surgery, and of course the prestigious reconstructive rear foot and ankle surgery. He's also the fellowship director for the Associates in Medicine and Surgery, Sports Medicine, and Reconstructive Foot and Ankle Fellowship in Naples. Further, he actively treats both ends of the spectrum as far as athletes from high school, Division I college, professional arenas, and of course the average Jane and Joes like us, but an esteemed clinician, lecturer, and instructor. We're just grateful to have him on the team. Again, please welcome Dr. Eugene Batelli. Dr. Batelli, I'll hand it over to you.
Thank you so much, Brandon. But wow, like I got some big shoes to fill right now. I'm an average person, just like everyone else. But thank you so much. There's foot and ankle surgery. There's not too many things that have really stepped up to the plate, and I hate to use this term, been a game changer, but this is actually one of them, and I'm really enthusiastic and excited about this particular product. I'm sure this is nothing new to you guys, that you go into a surgery, especially a first MPJ case, a Freiberg's case, and it's just really bad, and you're just looking for something else. I think that's where Subcon really steps up. I'm just going to go over just some basic stuff. I know you guys know this all, but just for completeness sake, talk about a little bit about the subchondral bone and the cartilage, how they function in conjunction with each other. Some of the pictures down there, I'm sure everyone has seen. So our osteochondral defects, injuries, damage, and our end stage result is going to be osteoarthritis. The importance of the subchondral bone, basically as a supportive structure, supports our cartilage. When that fails, it leads to the fissuring of the cartilage and the ultimate breakdown, leading to arthritis. Osteochondral injuries affect up to 27 million patients a year in this country. The native healing is very limited. The disease does progress and eventually leads to your cartilage failure. Just some pictures on the side of our injury, our osteochondral lesion of our talus, and the microscopic views of what happens to the cartilage with cartilage loss and the fissuring. These injuries are permanent, obviously. There's a whole cascade that occurs, both chemically, which leads to the eventual mechanical breakdown. Eventually, you get the bone to hypertrophy and lead to osteophytes. Cartilage does have a poor vascular supply. Adult chondrocytes do not migrate, or they do not replicate. If we're lucky, we get a little bit of fibrocartilage to the area. These are arthritis. This end stage arthritis does lead to about 500,000 procedures annually. So what have our treatment options been in the past? Chondroplasties, our abrasion arthroplasty, or basically fracturing of the subchondral plate, debriding it, osteochondral allograft, autologous chondrocyte implantation, which is extremely costly, and finally total joint arthroplasty or arthrodesis. Abrasion chondroplasty, shaving away the bone, has a long post-op course, not very reliable, yields more fibrocartilage than anything else. Studies report 75% of patients improve, but I got to tell you, my personal studies over 25 years of private practice, they do not do well and usually return within 1 to 3 years complaining of further pain. Our subchondral drilling, different type of picks, or your microfracture sets, basically the same outcomes. Osteochondral bone plugs. I remember as a resident doing my Oates procedures, and I thought it was the greatest thing. Maybe it's me, but my Oates patients do not do very well. They seem to do okay for the first 3 months, but then you get excessive amount of scar tissue formation. You don't get the true hyaline cartilage in there, and it does heal with fibrocartilage. And they're not very happy long term. Chondrocyte transplantation, once again, it can produce hyaline-like cartilage, but is also limited on how big these defects are. Let me get back 1 second. Once again, these are very expensive procedures. I've heard some in excess of $25,000, and some of them are being done by the military, which is absolutely bizarre to me. Minced cartilage, autogenous, allogenic, scaffolds. You need some type of glue or suturing into place. And once again, you're basically relying on blood flow from the bone, so your microfracturing technique does produce some stimulation, but you're still not addressing the subchondral bone or your support system. So it really was time for a novel approach. And for osteoarthritis and the treatment for both open and arthroscopically assisted surgeries. And that's how kind of I met Brandon at my Florida annual meeting. I was actually looking for an alternative to a abrasion chondroplasty for my daughter's volleyball coach, and sure enough, I happened to meet Brandon, who had the right tool for me. So the FDA has cleared S-Core HA implant. It enhances bleeding through the marrow channels. It has a chamber designed to provide structural support. And that's one of the main issues that I found with my microfracture, is that there is no support for that subchondral bone that is damaged. And eventually, any of these procedures, even if you did a cartilage transplantation by itself, eventually they also failed. And the FDA has currently approved the S-Core for bone and soft tissue to bone fixation. Here's just a quick picture series of a defect on your upper left. It's drilled out with the appropriate bits that come with your set. The fourth picture shows a acellular dermal matrix, which is actually sewn onto the S-Core, and you could insert that right into the defect. My option of choice is to do a cartilage transplant with either biocartilage or with Cardimax. There is de novo also, but obviously cost issues might limit in your surgery centers or your hospitals. And this quick video, you can see it threaded over the cannulated wire. So basically, you're going to identify your defect. You're going to insert your guide wire. You have your drill bit with your reamer, where you're going to debride your subchondral bone. And then the insertion of the actual implant. So these are just some quick pictures. Obviously, everyone has seen these. Severe defects to the first MPJ, and one of our patients with a repair. One of the things I do want to stress is there is actually a decreased load, and we've analyzed this through a gait through the gait analysis, where there's less pressure seen at the great toe with the decompression of the area and the restoration of the mobility to the first MPJ. All of my bunions at this point are getting an MRI, because how many times have you gone in there, you thought you were going to do a quick bunionectomy, and then you noticed that there is a big cartilage defect. So now all my patients before their bunionectomies get an MRI, and if I see any cartilage defect on the scan, obviously I'm going to order S-core in. Freiberg's, same thing. You want to see how big the area is, and a lot of the times it's going to lead to a joint restorative procedure than a joint destructive. So here's just a quick case study. 69-year-old male with joint pain. The procedures performed were an osteochondral lesion repair, reconstruction with an S-core and an allograft. This patient was non-compliant and pretty much did everything opposite which was instructed. Went hiking on his second day post-op. He went back to work on his third day, but he was still happy with the outcome, which is extremely impressive. This is a case where I did the MRI, saw that there was a defect on the plantar aspect, and patient's pain was actually pinpointed to the area. Not your typical classic central osteochondral defect. So I did do a joint decompressive osteotomy, basically in Austin, but a little more proximal with an extremely long arm to fixate it to give me enough room to put that S-core in there. In hindsight, I'm not too sure I'm going to be doing many head procedures with this. I think a base procedure would definitely be better to decompress the joint because of just the amount of bone there. I happened to get lucky. This was a large person, so my first metatarsal was big enough to support this. But you can see that it is more on the plantar surface. This patient I actually just saw on Monday, and he's back to playing basketball as well. He's about 28 years old and doing extremely, extremely well. My graft of choice to augment is either Cardimax from Into Bones or biocartilage from Arthrex. I feel they provide one of the best scaffolds. The only issue I saw with Arthrex was I did need to use fibrin glue to adhere the cartilage graft, as with Zimmer's de novo, and it did lead to a little bit of scar tissue formation where the Cardimax kind of fills in like spackle, and I feel it's smoother and you don't get as much hypertrophy of the area. Serial radiographs show the incorporation, and you could actually see that defect fill in over time. This was actually the case where I went and was searching for an alternative. from my daughter's volleyball coach. And he basically injured his ankle playing professional volleyball when he was 17 years old. So he had this large osteochondral defect. I was able to perform it, the majority of the procedure arthroscopically, and then put a small 2.5 centimeter incision to get the implant in there. But worked out extremely well. He's about 9-10 months post-op at this point, and he runs around with the team and does everything that he was doing pre-injury, basically. He is extremely happy with his surgery, and has definitely been one of my best advertising points. Basically, those are my slides, and I really like to open up to questions because, like I said, I hate to be very cliche, but this really was a game changer. I think my results have gotten so much better with my Freibergs. I'm not just jumping right to a spacer implant. With my first MPJ cases, where I'm just going into a simple bunion and getting caught with a cartilage defect, so my microfracture was producing a lot of scar tissue. The range of motions are much, much better after an S-core than with just a simple abrasion chondroplasty. I think my long-term ankle cases do much, much better as well. I'm not seeing the failures that I was seeing with my Oates cases. So my main point is this is definitely going to help your practice. The patient satisfaction rates are extremely high, but you really should get the imaging studies to confirm what you have, to make sure you have all the stuff you will possibly need for your case.
Thank you so much, Dr. Batelli. Actually, a couple questions, but one that I see, as far as early to mid-stage OA, and now that you mentioned getting imaging and MRIs prior to surgery, what would you say to other colleagues and other physicians out there who are looking to fuse or looking to do an arthroplasty? Where do you see the S-core fitting in that space, and when to qualify and catch these patients a little bit earlier to address this breakdown and like I said, early to mid-stage OA? What would you say to your colleagues from that standpoint?
I agree. It's definitely the early to mid-stage. I mean, if you have severe destruction to the proximal phalanx and the first metatarsal, you have severe osteoporosis, I still leave. Let's put it this way. If I have basically greater than 50% articular damage to the first metatarsal, I'm most likely going to do a joint destructive procedure. But if I have 50% or less, I'm going to go with the S-core. The sizes are large enough to encompass the entire lesion. I have a structural support now, so when I put that cartilage graft, I'm a lot more confident that it's not going to subside, and I'm going to be left with a defect in there that eventually is going to lead to further arthritis. And I think the patient satisfaction rates alone show how good of a procedure this is. Just a quick aside, and I don't about billing. A lot of the time when we do these procedures, you go in there and you're doing your bunionectomy. Okay, you see a defect, you're going to microfracture it. Maybe you have biocartilage hanging around and you're going to put it in there. It's really billed as an unlisted procedure. There is no procedure for cartilage transplantation of your first metatarsal. It is not an Oates procedure. It's a first metatarsal. So one of the vendors years ago suggested billing it as an open reduction internal fixation because it's technically a subchondral impaction fracture of the first metatarsal head. And I agree with it. However, if these get audited and the insurance companies are looking at this particular radiograph in this chart, you have no internal fixation to support the subchondral fracture to put your biocartilage in there. I think now you have another avenue to basically support what you're doing and get paid for it.
Yeah, those are great points. We've actually talked a lot about that internally, including, the Zimmer, what is the subchondroplasty, where they used to be able to bill for those particular fracture codes, like you were mentioning, as a providing structural support, which isn't the case. And now we're seeing pushback and some denials from that standpoint for the very reasons you're saying. So I think that's a very, very important aspect, that you just mentioned. So thank you for seeing that as well. Any other questions? I think another one I would ask is, do you feel when it comes to, like kylectomies and even bunions, where, like you mentioned, you may see a defect intraoperatively because of the alignment, when you fix a bunion, do you still think it's important to potentially address the subchondral bone aspects, because of certain breakdown or maybe things that, again, doctors or physicians aren't necessarily getting those preoperative MRIs, but you do see a little wear and tear? Do you think it's important to still look at the whole med head, from a potential problematic standpoint of breakdown in that subchondral bone, even though maybe alignment's fixed? And maybe you see that, when a patient comes back in for follow-up and you're doing range of motion or weight-bearing range of motion, and like at that mid-range of motion, they still have a little pain, maybe some swelling, even though alignment is addressed and fixed per se, if that's something to consider.
Absolutely. And once again, since identifying this defect and being able to repair it, I'm noticing increased range of motion, much less scarring. There is definitely less post-op stiffness, post-op pain. And anytime you go into the capsule with a bunion, you're going to get hypertrophy of that capsule, which is going to limit that range of motion. But then having that defect just further hunkers down that joint where it does not want to move. And no matter how much home exercises the patients do, no matter how much physical therapy, how many injections you try to give it to break that scar tissue, it never really improves. But just as an aside, as doing this, like I felt I was doing the right thing for the patient, but I'm noticing that the range of motions are better. There's less scarring. There's actually an anti-inflammatory effect when you're repairing that subchondral bone. It's just like any other fracture, even your ankle fracture. You're gonna have a chronic swelling if it's not fixated. But once that bone heals, it does real well, and you have much less swelling following these procedures than the ones that I did not address the subchondral fracture.
Awesome. No, I appreciate that. Thank you for that response. Any other questions out there? I just want to make sure we cover everything. And if not, listen, again, we'll be doing another follow-up. Be looking on LinkedIn for our next webinar series. If anyone has any questions, Dr. Batelli, I believe your info is on the beginning of the slide, but I can definitely share that. And any of your surgeons that may want to reach out and ask them questions, anything to follow up with from the presentation tonight, I'm sure Dr. Batelli would welcome any and all questions his way. So really appreciate your time, Dr. Batelli. Thank you so much.
Thank you, Brandon.
If anyone else has any questions,
thank you, everyone from Subchondral Solutions.
All right, everyone, listen. Well, thank you again. Have a great evening, and then be looking out for LinkedIn on this. And if anyone wants a copy of this presentation, we'll be sure to send it out to you. Feel free to reach out to me directly, Dr. Batelli, or anyone with Subchondral Solutions. We'll make sure you receive it. Again, thanks, everybody. Appreciate it. Have a good evening, and we'll catch up soon. Thank you.